afternoon, everybody. My name is Doug Dahl. I'm the Communications Officer for the Health Region, but this week I've been the team lead for Team Dilbert. This is a wonderful picture of Team Dilbert, the people who've been working all this week on our project. Our project is about reducing wait time for patients by reducing the lead time for specialist consults in the emergency department at Victoria Hospital. A project form, we have some data. It's hard to see some of the small charts. In the ER, we average around 8 or so consult requests per day to see patients in the emergency department. In addition, there are a few other consults that come directly in from either community or other communities outside of the Victoria Hospital. This is our pre-Kaizen value stream map. This is, it looks at the process from the time the decision was made for a consult request to when the specialist sees the patient. The key component in there for work being done was the referral process. When we were measuring, it took about 4 minutes for that. The big part of it is a 3-hour and 24-minute wait time, which left value-added time for the patient at 1.9%. Our target progress report result sheets. This is our baseline for the beginning of the week. We've got a number of different measures on there. A couple of key ones for us are the lead time around patient ER time and request to consult. Average patient ER time from the period that we had measured pre-Kaizen was over 5 hours, and wait time again was 3 hours and 24 minutes. And the cycle time to do the referral was 4 minutes. The TAC time in the emergency department for an average of about 80 patients a day is every 18 minutes. There is a slight difference between day and night. In the pre-Kaizen period, we looked at a SWOT analysis. We've got a lot of specialty groups. That's very much a strength. We've got qualified physicians and nurses. They're all dedicated to improving the care for the patients. One of the big challenges that's been identified is the workload that the specialist groups have when they're on call outside of responding to calls to the emergency department. The next one is a fishbone. We took some of that and some of the problems we identified and applied it to a fishbone. We're focusing on specialists and the ER doctors. And at the beginning of the week, you will notice we had a lot of NUDA. Most of it was regarding wait times, but also things that influence the wait times from the specialist perspective.
Hi, my name is Randy Friesen, and I'm a general surgeon, and lately I've been a caregiver as well for a member of my family. So, this sheet very adequately tells you where we started from with this project. There is no standard work for specialists getting consulted to the emergency room. There are traditions, there are rumors, there are suggestions, but there are really no written down or even widely accepted standards. So we had a great starting point. Everything we would do would be a great improvement.
So when we looked at some of our idea summary sheets, we know that there are patients coming to the emergency room department with less urgent needs, CTAS 4 and 5. So we were wondering if we could look at some way of referring these patients back to the specialist office. Another idea was we had no criteria, so could we even ask for an estimated time of arrival? Each physician in the emergency room practices a little bit different, even how they do their consults. So could we standardize this work? And again, there was no criteria according to how to get them there in a timely fashion to enhance care for the patient. And the staff training for Sunrise Clinical Manager as well. Each physician is not trained and does not know how to use it. So could we develop something to that?
So how did we arrive at standard work? When we approached our colleagues who were on call and asked them what they thought the average wait time was, we had suggestions like 30 minutes. So our colleagues were dismayed to find that the actual measured time is 3.5 hours. Every colleague we spoke to was very keen to improve that and was quite certain that we can improve that and should improve it. One colleague said the solution is just punish them if they don't show up quickly. However, we thought we'd be a little more dignified and tactful. So we have a tool that we can work with. Every patient who comes to the emergency department is assigned a CTAS score, Canadian Triage and Acuity Score. That is based on objective criteria. The scores are assigned by the triage nurse who is trained in how to do the triage process. So the emergency room doctor then knows before he even sees the patient, he or she, that score gives them an idea of the general acuity of the patient. So the emergency room physician then assesses the patient and might modify the score a little bit, but then still has something very objective to present to the specialist. As specialists, we often hear stories, but we don't have a CTAS score. So the time when we feel we should arrive someone subjective, there are national criteria for emergency room physicians. We don't have a national standard for specialists. So we took the emergency room physician times, modified them somewhat because we often have other commitments, have to travel, etc., and came up with a draft of what we think could be standard work. CTAS 1 and 2 patients are patients who are very, very ill. So we've set up a timeline of immediate, or if you're outside the hospital, maximum 30 minutes. If the patient is acutely ill but not immediately life or limb threatening, that's CTAS 3, 60 minutes. If the patient isn't likely to have a life or limb threatening condition very shortly, they're CTAS 4 or 5. Unless the physician can come immediately, the best thing to do, the most efficient thing for patient, for doctor, for the system, is to send that patient home with the promise that a consultation will be obtained outside the emergency department in the very near future. So this is the guts of what we presented to our specialists who were on call this week. Surprisingly, they were all very receptive. In fact, some of them were keen enough that they wanted a reminder call when their estimated time of arrival was not actually in fact kept.
And part of that is, of course, a huge education piece. So we have developed some work standards for Sunrise Clinical Manager. And we have taken and developed a step-by-step and also posted that in 2 key areas of the emergency room where the physicians can access it. So we put it in blue paper above the computer and have started some of our multiple skills training list. And the group that you see here is general surgery.
I'm Denzel Severa, one of the doctors in the region. The task we are doing first was to change the consultation forms. This is the old consultation form, was a 3-part form, which the first part was to the medical records. The second part was the yellow form that used to go to the family doctors or the emergency room doctors. The third part was the pink part that the specialist used to take. So this one basically shows you a 3-part form. You notice a lot of wastage happening in this form. Is because it's a pressure sensitive form, when you used to write in the form, it used to frequently not go to the second and third form. So the second form used to get frequently wasted. The emergency room doctor didn't want it. And a lot of patients didn't have any family physicians, so it just got wasted. And the specialist used to take the third form, and the most important thing for him was the patient's details. So what we did is we spoke to the users as well as the medical records. The medical records, what they used to send over the forms to the family doctors. But they used to photocopy the first form and either fax it or mail it to the family doctors. So we came up with a new form after the 4th draft, because this is the final form we've got. It's a 1-part form, and it's got a couple of things that we're pretty happy about. One is that it's got the CTAS scope, and it's got the time, expected time of arrival for the specialist, and there's a recall time of the expected time of arrival as passed. There's also the consult type is slightly different, it's just a tick box now. It's got a form, they said picture or name for both the emergency room doctor as well as the specialist. There's also a small section on the bottom there for the name of the family doctor. And if the family doctor is to be contacted, we have to take that as part of copy center. Most of the specialists nowadays use electronic medical records, so we fax our own forms straight to our office, and it's easier to get that. For some of them.
I'm Alana, and I work at the big hospital here in acute care. So with the development or the revision of the form, we were also able to develop some standard work for the OR doctors here. A very important part of that standard work is when we start the consultant to see time, or when they started in Sunrise Clinical Manager, because this gives us a consistent start point to be able to start timing when the specialists are actually going to arrive. So with our standard work, we developed training. As you can see, some of our ER doctors have started their training, and we also posted the standard work steps at the workstation. We have done some observing and recording, as you will see on our time observation forms, and we took this data and we compared it to the data that was collected pre-Kaizen. So as you can see on our percent load chart here, the time that it took for the physicians to fill out the form actually stayed the same, even though we had some additions of the CTAS time and the estimated time of arrival added to the form. The difference was the length of call of phone calls, which is quite standard because of the different conditions and the different physicians involved. So in summary, our work, what we have as a result of the physicians are work standards for the ER doctors that gives us consistent data. We reduce the waste of the form by going down to one page from 3 pages. The specialists have a consistent reminder that they have a patient waiting for them, which they appreciate. And most importantly, we increased our patient satisfaction because now they know when to expect to see the specialist.
Hello, I'm Neil Martin, the ER physicians here at the hospital. So as part of the RPIW process, we were asked to perform a play best task. Specifically for us, we looked at the suture materials in the emergency department, the amount, location, and portability, and then addressed the waste issues regarding them. So this is pre-Kaizen of our suture materials in the emergency department. You see that it's located in multiple locations. There's excessive stock of certain suture materials. Some of the stock is even expired. Some of the suture materials we don't actually use as ER physicians. You can go to the next one. There's no work standard for who's going to be restocking the suture, when we're going to be stocking it, what we're going to be stocking it with. As you can see with our cart here, it's very non-user friendly, as well as at times it's quite hazardous and unstable. So pre-5S, we and Anton evaluated us, and as you can see, on most of the criteria that they were able to evaluate us on, we got 1, and 1 being poor and 5 being excellent. So we did quite poor on pretty much every area that they were able to assess, with an average score of 1.1, so just barely above poor. So we came up with an idea that somehow we're going to try to improve the suture materials, the suture cart, and the ER department.
Hi, I'm Lynn. I'm one of the nurses from the emergency department. So with the help of the nurse educator from the emergency department and the maintenance department, we were able to put together a new suture cart. So we now have one central location for all the suture materials in the emergency department. A movable cart that we can take with us anywhere we need to go. So this eliminates the multiple locations in the department to try to find the suture materials. So less steps and less time to try to gather the materials needed when suturing. We also developed a standard inventory list for the cart. We removed over 500 items from the emergency department that were suture-related items, 134 of which were expired. So hopefully having the one standard location as well will improve the turnaround of supplies used and eliminate the stock being expired. We also have created some work standard for the quarters in the emergency department in terms of stocking our current floors. And so our barely above poor score of our pre-5S evaluation has been significantly improved from 1.1 to 3.75. So we've increased significantly in our accessibility, clearly enabling, having only the necessary items stocked in the department is the one location we have to get supplies from.
Good afternoon, I'm Ian Johnson from maintenance here at the VIC. I was also sub-team lead for this wonderful team. You can see post-Kaizen here we have our targets report sheet, and we've made some significant gains. It's always hard for me not to make gains on everything, but as with any process, there's roadblocks and other issues that cannot be solved in a week. One of the significant gains was the 5S. We made a 53% increase in space and a 69% reduction in the suture stock. Notably, that is about $1,000 worth of stock that was eliminated, and it will be ongoing savings as the stock will be smaller from now on. We also reduced the lead time, and the consultant referral time is almost 84% reduced. Spaghetti diagrams didn't change here. We did not alter what the doctor had to walk for the referral or the form travel. On our value stream map here, post-Kaizen, basically the referral process remained similar, but it was standardized. But when we set the expectations for the doctors and made it standard work, we had a considerable reduction in the wait time. It's 32 minutes here. The value add is 15.1%, which is up from 1.9%, so that's a considerable gain. And our newspaper here basically shows that we wrote a lot of work standards and standard work, and moving forward we will need to be training people and the doctors, nurses, and everyone else involved. So this is an ongoing process, and I had a great week. Thank you.
Good afternoon. My name is Ken Weiss. I'm a patient. I'm better known as the inpatient patient. It's been a really interesting and informative week for all of us. When you spend a week in a relatively small area, you get to look at things very, very closely. And you learn things that you weren't sure about, and some things you find you didn't even know about, and that includes the people that work there. For patients looking at and from the inside point of view in the ER, it is absolutely eye-opening and eye-opening. Thanks to the senior leadership team for supporting the RPIW by providing the people the time and resources to complete our tasks. As you already know, RPIWs allow for quick changes that help you keep up and improve the constant need for change. Thanks and appreciation for the help and support of Dr. Elise Payne, ER nurses, Tracy Hodgson, unit clerks, Dr. A. Martin, Lori Bolotnick, Dr. Alley, ER doctors, maintenance, specialists, health records, Tammy Gillis. And for your insight and guidance, Ergato, Cincy, and Ricky. And a special thanks from me on behalf of all patients for the service you perform and your unending quest for continuous improvement in your application of your knowledge and energy. Kate Gilbert.